This is adding imaging services to the patient-centered medical home. Zara Masalian, M.A., is the CEO and co-founder of La Maestra Community Health Centers. She founded La Maestra to provide multicultural health care and social services to immigrants, refugees, and other underserved families in the inner-city San Diego area. Since 1990, La Maestra has expanded to serve patients in several areas of San Diego, including City Heights, El Cajon, National City, and Lemon Grove. Funding is received primarily from the Bureau of Primary Health Care in Public Housing and also through foundations and collaborations. Zara holds a master's degree in organizational management and has been actively involved in community organizations and other nonprofits for over 25 years. Zara is a member of the American College of Healthcare Executives and graduate of the National Association of Community Health Centers Excel Leadership Program. Zara is also a dedicated member of several boards of directors in San Diego and former president of the Council of Community Clinics. Zara has been recognized locally and nationally as an ambitious champion for the cause of helping the uninsured and improving access to culturally competent health and social services for the diverse communities of San Diego. In 2004, she was one of 10 leaders to receive national recognition from the Robert Wood Johnson Foundation with the Community Health Leadership Program Award. In 2007, she received the Green Lining Institute Lifetime Achievement Award in recognition of her vision and leadership in healthcare. And in 2009, Zara received the Excellence in Health Services from Chaldean and Middle Eastern Social Services. So here is Zara without undue delay.
Thank you very much. You're welcome. I don't know, we need the microphone. You can hear me, right? Okay, good. Thank you. First of all, thanks a lot for coming to the presentation. I wanted to acknowledge that we have one of our board members here, Alexia Ochola. So if afterwards you want to ask us questions about the organization, this is the guy to ask. No, he's one of them. We also have our COO, Alejandrina Arreizaga, right back here. And my co-presenter is John Lathine. He's the director of our imaging unit. And he was on our board for 5 years before we embarked on this project. So he had a good understanding about community health, about the challenges not only of the diverse communities that we serve, but also from an organizational perspective. So that's really cool. Here you see the mission statement for La Maestra. I'd like to just take a second to let you know about our beginning, because that is, I think, one of the truly unique features about La Maestra. We did not start as a healthcare provider. In 1986, we started as a nonprofit educational-based nonprofit organization in City Heights, which is a very densely populated urban setting in San Diego, central San Diego. And there are numerous languages spoken there. Lots of immigrants, refugees have traditionally settled there and been settled there by the agencies that bring them over to the United States. So we started off providing English as a second language, doing job training, doing child development, literacy skill development, and primarily helping people figure out how to apply for amnesty. Because in 1986 there was the Immigration Reform and Control Act passed by Congress. So basically it was a window for people who'd been in the United States for many years who could prove that they had been working, that they paid taxes, and so forth. There were many requirements. One of them was filling out the form, getting all the attachments, translating them, also proving that you speak enough English to be able to pass the test. So this was huge. We had 12,000 students attend the program. We were open 7 days a week and late at night. because people were working, we had to accommodate the schedules so that they could come in for these services. Well, when people started coming in for the services, they're going to tell you about everything else because you're the person that they're now bonding with. And that was cool because this was the first time many people had the opportunity to trust somebody enough to ask them or to tell them, hey, this is what's going on, what do I do? So we were listening to that. We also had the student council that was formed. And in 89, they really started getting emphatic about needing healthcare services in our community that were culturally competent. We had many people come forward and say, look, my baby, I took him the other day over to this other place. They didn't speak Spanish. They didn't speak these other languages. I don't know what kind of insurance I need to have to access the care. I don't know how to fill out the forms. If I go there, are they going to report me for something, even though I haven't done anything wrong? My aunt, she lives with us. Maybe her papers aren't, her documents aren't approved yet by INS. Are they going to know about that? Are they going to deport her? I mean, these are ideas, perceptions, and oftentimes very true kinds of worries that people have in actually going and accessing the care. So we thought, all right, we know that education is super important in terms of making a change. We're from we're a real grassroots organization. Why can't we just add on some other services like health care? We didn't know anything about licensing. We didn't know what a licensed community clinic was, much less an FQHC, a 330, managed care, none of that. We soon found out because licensing showed up. And fine. We made the adoption of whatever all the regulations that then we learned quickly about, bringing all of these buildings that we were in up to code to meet licensing standards, being able to provide the services that was so apparent when people were walking in the door that they needed. We started 2 half days providing peds. Well, you can imagine. And there comes the prenatal. Then there comes the aunt. Then there comes somebody else. And it was amazing. We started with a base of 12,000 students, and quickly it grew. Quickly. And then we formed the La Maestra Community Health Centers as a separate 501c3 specifically for healthcare services. And we kept all of the other services under what now is La Maestra Foundation. And you'll see shortly what I mean. So I've kind of gone away with this. That new building you saw was really cool. We just were able to build it after 22 years, okay? Getting out of the old 14 old residences from the 1920s that I'm sure only were still standing because we were in them. With our 80,000 visits a year at that time. You can see the unduplicated patient visits. I'm going to get out of your way here. And how it grew. This demonstrated the incredible need in our community. We opened up other sites, like you heard in the introduction. We have about 6 sites throughout San Diego County. The populations vary in terms of their ethnicity. In City Heights, which is our central headquarters, there are over 20 languages spoken each day. Always have been. It's getting more. So from the beginning, one of the models that we'll talk about here in a minute that have been very innovative because of the way we started, because of how we developed, is that we are very culturally diverse, and our staff come from the populations that we serve. Now, that's a bit challenging when, for example, the latest population to move into our neighborhoods are the Burmese. So it's very difficult, obviously, to find a Burmese who is willing to work in our setting, who has the medical background that the state of California is going to recognize. Okay. So what we do with that is we find people from the community, we work with the leaders of the community, whether it's the Somali, the Sudanese, the Burmese, to see in their culture, who is it that's the designated, okay, let's talk, let me hear what you have to say, I'll open up the lines of communication to our community, and I'll encourage them, members of our community, to talk to you. Well, in the Sudanese communities, it was the leaders, the older people that had been respected leaders for a long time. I mean, obviously, years, but in the United States, we know how that changes, too. And with the Burmese, for example, it was reaching out to people in their community that they had respected because of knowledge. They had either been doctors, let's say in the refugee camps where they were stuck for years, even though they weren't going to be doctors in California because of the language barriers. You know, perhaps years from now they would be. This has happened with our other refugee groups as well. You see some that are able to pass the boards and some cannot, so you use them as health educators and you see how you can integrate them and use their skills, because these are wonderful advocates that can be the liaison between the provision of services and the community. They educated us about, listen, our populations are not going to follow the standard care of treatment because they believe this. They believe this is bad for them. We had one group tell us that they believed that there was common belief in the community that the test for diabetes is actually what gives you diabetes. Okay? So you can imagine if we had trotted out a cookie-cutter approach and then go find out how much later that it wasn't going to be effective. So it's not just the formation of the message. What is the message supposed to contain? How to deliver it? What's an acceptable way to deliver it? Many of our populations will not look at the back of the bus for an important message about their health. That's not where they're going to look. Okay? It's got to come through the right method. So basically, that's the method that we have in putting together, in gathering information, working with our community, all the diverse cultures, when we decide to roll out a program. And why do we decide to roll it out or even think about a business or feasibility plan? It's because of the need that presents at our health centers. An incredible need that we document, we listen, we talk to the communities, we talk to the providers, and so forth. So those were some of the innovative models that we've been working on: telemedicine, school-based health, so forth. Well, over the 22 years as a clinic, and going back to 1986 under the Amnesty program, this is what we've formed, the circle of care, because we know that it takes more than a trip to the doctor to achieve wellness. These are all of the other programs that we are offering right now that have been developed throughout the years. Some are in the area of housing. We have transitional housing for people in recovery. We now it's the veterans as well that are returning from combat, and they are, of course, the residents of public housing. These green are all of the job training, the economic development, job training and placement services. We also have microcredit program that we started about 5 years ago. It's fantastic. This is for the poorest of poor women, and it really works in our communities. Also showing people how to develop their own business. We've had great success at this as well. Community Garden has come along with our food pantry that we opened up about 10 years ago when we found that many of our families were going hungry halfway through the month. A lot of the seniors didn't have access to food, or they didn't know how to access it. It's amazing when I first heard about the food desert. I don't know if you know what food deserts are. You could be living in the middle of the city, but you're in a food desert because the food that you can afford to buy isn't good for you. It's junk. And maybe you can't get to it even. And you don't know where to shop. A lot of our folks go and shop, how many places to get the produce here, this over there, this over there. And so through this food pantry, that's another way for us to do education, outreach on various services with populations that are in the line. They're already there, so that's our opportunity to talk to them about some other programs that they could benefit from. And that leads, of course, to the nutrition education, and really, again, they who are in those lines will come and tell us, you know what, this is what's happening, having this issue here, I don't know where to go to access this service, my mom's sick, whatever. So there's always a way to hopefully integrate people into some of the services that we have or our networks of collaborating partners. This circle now is getting pretty busy. They're just like, now the last one is the legal advocacy services. Because a lot of folks, they have legal issues. There's not enough attorneys that are willing to work with our populations. And one of the programs that we really work with is the whole human trafficking. And so you get the T visa, the U visa, the domestic violence. And that brought one sector of legal services that were really needed there in the community. We all know how many other family law, getting restraining orders, dealing with lots of issues. So anyway, that's one that we're now brought in there. Doesn't mean we have tons of attorneys, but we have people who can filter in what the needs are and then work with our collaborating attorneys. So this just gives you an idea of how our organization developed and why we're going to be talking today about the imaging unit. Again, this gives you some idea about the different programs. If you look at our website, you can see more. This was an initial chart of how we thought we were integrating these programs. They kind of take on a life of their own anyway, so it was just us stepping back and saying, how is this working actually? How is the rubber hitting the road there? We talked about that. These are some of the languages. This was the medically trained cultural liaison program I spoke about already. Telemedicine, it was another innovative program. Now we just finally got a mobile clinic through a grant, which is great because we're already at the schools providing medical services, but dental, we all know how difficult and expensive it is. It's not feasible to go put dental in how many schools you're in. Plus, we know the schools get their reimbursement through ADA, average daily attendance, right? So the districts are going to collaborate much more with us if we go to them and say, you know what, you'll still be able to collect your average daily attendance for the kids because they're going to still be on campus. They'll just be visiting our mobile clinic. So it's a win-win all the way around. Now I wanted to introduce John Lathine. There he is over there, in case you don't recognize his picture. He's the director of imaging, and basically he's going to be talking about how and why we decided to offer mammography services in our community. And what does that mean and why and how did we go about it, and also how we started with the other modality, which was the ultrasound for the prenatals. And you'll see how we moved from the prenatal to the general ultrasounds, and then that gave us the confidence to embark on mammography. But one thing I wanted to definitely say before I bring him up here is that Since 1992, La Maestra has been committed, really an advocate for breast and cervical cancer screening. That's when the CDC came out with their first program, which was called BCCP, which was Breast and Cervical Cancer Screening Program, the first program for very poor women who were basically underserved in our community. The first time that they were able to access breast cancer screening and cervical cancer screening services. And so we were the first clinic in San Diego to do this. And our doctors went and they received training and so forth on, you know, how do you roll this out? And we shortly found out that, okay, you screen people, you tell them, you know what, you have some abnormal finding, or you have cancer, God forbid, now what? What now? So then that led us and prompted us to go and find a network eventually of oncologists, radiologists, working more with the hospitals to see what resources we could bring to this dilemma. Really, it was tremendous. So we used some of those networks and partners to call on when we were exploring this whole issue about, hey, can we do this? Can we bring on mammography? Because since 1992, we have developed and managed the breast cancer education, community education, the outreach, the promotora programs, the screenings, arranging for the screenings, also doing the case management. We've done it all. The only piece we didn't do was the actual mammography piece. For that, we had to engage a company from Los Angeles, 2.5 hours away, to come down once a month or twice a month, and we had to batch the patients together. Well, from how many of our sites? It was very difficult. Batch them together, do all the paperwork, have them ready, and, you know, it just was not, you know, it wasn't a doable situation. The two other imaging centers that are in San Diego are far away. Okay, it's like 20 minutes by car, but if you take public transportation, you got to go through how many different bus changes and so forth, plus the languages and so forth. So anyway, that's what led us to where we are. That's why we had a passion for finding out how to do this however we could. And John's going to come up here and tell you how we did it. Okay? I'd like to introduce John Lathine. Come on up. John has 24 years plus experience working in major healthcare organizations, Kaiser, including Kaiser, doing ultrasound, as an ultrasound tech, radiology tech. So he understands, you know, all of the needs and of the populations. He also brought with him a huge resource for us in terms of providers that he's known over the years, radiologists he could call, and plus he was on our board for 5 years, so he really understood our management, the executive team, the other board members. So yes, quality super important. Super priority is patient care and good care. Also, you got to convince executive management that this is something that's doable, okay? That you're not going to all go broke. It's going to be sustainable. We know that. So this is what he did.
Thank you, Zara.
Thank you.
Thank you guys for coming out. I hope I'm able to add a little bit of information that you guys will find enlightening, enriching, as you guys participate in your journey to adding imaging to your FQHC. I want you to know that, first off, this is just our model. This is what we chose to implement, and each case is going to probably be unique because every FQHC is a unique entity. So I just kind of wanted to share with you our process of implementing imaging services. So, okay, let's see. So why would we add imaging services to our FQHC? What we're going to do is we're going to increase access to care. We're going to increase our patient compliance. Prior to adding imaging, a lot of our patients were being labeled as non-compliant. They weren't showing up for their imaging exams that were being referred. It was due to demographics, due to travel, due to taking time off work, child care issues, and language and cultural barriers. It was also we needed to bring specialty care into our community, imaging into our community, because it didn't exist within our community. And it's easier to offset self-pay payment costs. We were able to add a sliding fee component to that. So some of the benefits in our case were enhancing the scope of services in the medical home, providing access to affordable, quality, culturally competent care, enabling outreach, and we were just able to add a change of scope to our services. Also, with coupling education, screening, and follow-up, our patient navigation, our outcomes were much better. We had the ability to close the loop in our care. We had rapid reporting of abnormals that were taken care of on-site. We had rapid referrals to surgeons, specialty care oncologists. So we noticed overall improvement in patient compliance and in the care for our patients in total. We were also to form additional revenue streams for our health center, new funding streams by adding commercial payer sources. So we're now able to attract commercial patients, and we can bill for those services. And then we had opportunities, being able to generate some revenues to apply for grants and then cover some of the uninsured costs that we incur. So by implementing these services, we've added relief to the already taxed healthcare system. By adding areas of relief, we were able to reduce emergency room visits, lower some of the surgical and specialist costs, reducing hospitalization, rehabilitation by early and timely detection. We were able to reduce disability and unemployment. We were able to get our patients to return back to work in the workforce in a more timely manner. So our feasibility analysis, these were some of the feasibility components that we identified and analyzed. And it's the need, the interest in the community. Yeah, we had it. And I think if you guys were to look around, your communities probably need it as well. The in-house data, patient tracking. We looked at our data, like Zara mentioned, since 1992 that we've collected. We noted inconsistencies in case management process when with the mammography services that were off-site or mobile. And we had a number of cases that were just falling through the cracks. We also looked at the available services inside and outside the health center, cost of those services, distance from the medical home and patient's residence, linguistic and cultural competency, and also case management that would be involved. Then we looked at the available resources, the expertise that would need to be available within our organization and broader network, funding sources, startup assistance, low interest loans, reimbursements, and what steps to add reimbursable services to your scope. So we chose to first implement ultrasound. We'll soon discuss some of the other areas, mammography, which Zara alluded to. As far as adding ultrasound to your scope, ultrasound from a regulations perspective it's a relatively easy specialty to implement. So with ultrasound, there's few to no setup regulations. You do need an ARDMS credentialed sonographer to perform the imaging, and then you do need a board certified radiologist for the interpretation or the reporting component. So when implementing Mammo, Dexa, Radiology, there are additional legal requirements and regulations. In mammography and Dexa in radiology, it requires specific plans from the manufacturer. You need to look at your space, architectural drawings, weight load, shielding, electrical requirements. You're going to need to bring in a radiation physicist to do some reporting, licensure of the equipment at a state and federal level, and then with Mammo specifically, you'll need to use the ACR and get MQSA accreditation. And then you're going to need to submit quite a bit of documents and images to the feds. So our feasibility analysis, it also included looking at the equipment and the modality options. So some of the services, ultrasound, mammography, Dexa, X-ray, radiology. The other thing that we need to decide is you need to look at, is it something mobile, or do you need to do, should you do a permanent or a fixed unit? With mammography, we chose to implement a fixed unit because that was due to a funding opportunity that was available to us. However, we'll talk a little bit more about some of the vendor relations that can be cultivated. With our vendor, when we went with the fixed unit, we were able to negotiate a second mobile unit at a very deeply discounted price that we have locked out, that we plan on implementing at a future date, maybe 12, 18 months from now. The other component is digital. That would be something that I would definitely recommend when you're pursuing imaging. You need to use teleradiology. It's where your radiologists don't necessarily need to be on site. They can read remotely off-site. By using PACS, you're going to need to incorporate an IT component in DR, which is our PACS and RIS, our radiology information systems. Digital will also integrate very nicely with EHR, like Mrs. Thomas Brown was speaking about earlier this morning. With digital, you'll have an HL7 interface that will go right on into your EHR, and it will just be seamless. And then also in mammography, we add digital because the resolution is much higher. You're able to detect cancers at an earlier rate. You're able to reduce the exposure to the patient. Cuts the X-ray exposure 40 to 50% digital compared to film screen analog. And then we can also add something called CAD, which is computer-aided detection, which is a second set of eyes that helps the radiologist read it, which is actually another billable component too in mammography. So digital is key. You have access to 24/7 remote interpretation. You have the ability to review images and reports at any of your satellite clinics that you may have. You have the ability to instantaneously beam the images and the reports to any of your beacon medical centers for any kind of surgical or specialty care. So we ended up just equipping our staff with the state-of-the-art, the highest quality equipment. And we did that because, first and foremost, we knew that it would be best for our patient care. What we didn't anticipate is how huge a factor equipment choice would be in attracting expert radiologists within our community. They're coming out of the woodwork to read for us. The commercial payer sources that are coming out of the woodwork to send their patients to us. And it helped us out with the accreditation process. When you have state and federal inspectors that come out and they see the type of equipment that you purchased and installed, it definitely helps out with that process as well. They become very impressed, and they see your mission clearly, and I think it makes it a little bit easier. As far as partners, we looked at which partners we could identify in our environment, which included some of our major medical centers, Kaiser, VA, veterans, and then some of our private radiology groups. So we also identified organizations who were able to contribute into the planning and implementation processes. So we looked at manufacturers. We took time. We invited them on site. We built relationships with them and had a rapport. We worked with teleradiologists. We interviewed different teleradiology groups to determine which one would be the best fit for our organization. We talked to local specialists that we knew after being in the community for years. And then we looked at different training programs within the community for our staff. So during our implementation stage, this is how we moved from our feasibility analysis results to developing strategies for implementation. So if the feasibility analysis indicated need, then we would proceed to gathering information. We would collect data from hospitals, radiologists, medical technologists, cultivate networks, building collaborations, funding opportunities, vendor relations, which moved into phase and services where we built trust with our providers and staff, which is actually key. You want everybody to be on board, keep them informed, value their input, let them know where you're going. We looked at what would be most cost efficient, showing how this will be cost efficient to our administration was huge so that everybody was on board. We cultivated networks with the radiologists, with the medical imaging technologists that we would bring on site to work for us, operate our equipment, and work with our providers in hospitals and et cetera. So we decided to purchase equipment that allows for future expansion. In our case, we are prepared to add stereotactic biopsy, 3D tomosynthesis. I'm not sure if you've heard of that technology in mammography, but that's where we're going. It's truly state-of-the-art. When you project adding these expanded services, we ended up having our rad physicists project that, because with tomo you're going to have a higher volume of x-ray, so your lead requirements are going to be different. So we had our physicists project tomo when we did our build out, which costs a little bit more up front, but it's going to save us tons of money in the long run and zero downtime. We're looking at expanding into mobile, and we also have 3D and 4D ultrasound capability. So we looked at how to integrate imaging into our existing services. These are a lot of the services that Zara had already spoken about. And these are some examples of what led us into mammography, which is really cool, very exciting. This is something that we just rolled out in March. Yeah.
The mammography.
Yes.
That ultrasound you see is 2000.
Yeah. So in 2005, we started off with ultrasound. We had one fixed unit, one stationary unit at our main clinic. In 2006, we started shuttling our satellite clinics out to our fixed ultrasound unit. In 2008, we realized that we needed to add additional equipment. So we started working on our vendor relations. We did provider interviews, polled our staff as to what it is that they needed and when and where. And then we started working on our vendor negotiations, and new acquisitions were culminated. In 2009, we purchased a mobile ultrasound unit that would provide ultrasound services mobily to all of ours. So we knew we had to buy equipment, so that's where we made the decision between fixed and mobile, because we had multiple satellites that we needed to serve. However, the volume wasn't there to scan at each satellite 5 days a week. So you have a piece of equipment that's sitting idle, So we chose one mobile unit with docking carts that we would set at our satellites, and we would bring the scan engine to each clinic, and we were able to operate that piece of equipment 5 days a week. In 2010, we added the general ultrasound component using teleradiology, where we incorporated abdominal, aortic, renal, thyroid, breast, pelvic, endovaginal, testicular ultrasounds. So with that, we created jobs because it required additional scanning, more days. We increased our patient volume right off by at least 15 per week. We also incorporated teleradiology at that time, where we would have our studies read out remotely with 24/7 access to care. And then in 2012, we started expanding our imaging staff. One thing, too, when we started out, before the imaging, we talked about non-compliant patients that weren't showing up. Now we have a 95% compliance rate in all of our areas. All of our patients come in for their imaging exams. Example of some of the patients that we've served in imaging over the past years. And we're projecting in 2012 our numbers to be probably close to 7,000. Okay. So this is our history with mammography. In 92 to 2012, so like Zara spoke, in 92 we had the breast and cervical cancer education screening. We would have the Mammo Days, where we'd have a company that would come out, mobilely shoot, analog, just blind 4 views, and send them. And then those would be taken up to another area, maybe 100 miles away from our community, interpreted by a radiologist, and the reports were sent down. It was a mammogram. The quality wasn't really there, but it was serving a purpose. And as we grew, we learned more, and we knew how to better serve our patients. We had clinic staff doing education, appointment follow-up, case management, doing the interpretation for the many languages that we speak, providing transportation. There was no reimbursement for staff time and enabling services. These were just all things that our staff had to absorb that on. And then during that time in 92, we still had a very low compliance rate for the exams, and then any of the referrals that needed to be generated out for any diagnostic, follow-up, surgical compliance wasn't that great. So after 2012, in March of this year, we ended up implementing full-field digital mammography. The benefits to mammography in the medical center home are better patient care, compliance with follow-ups, increased quality measures, specialty care is available at medical home. We created new jobs. We now have 3 mammographers, and we have 2 case managers, reception, ancillary staff. We have new revenue streams, reimbursements, grants, contracts, and cost effectiveness in our staff time. So right off, we just started at 3 days a week, 50 patients per week, and then we did internal orientation and marketing of these new services. We started with external. We would go out to the community and the other community health in the community that did not have these services. We noticed new funding streams and went after them, and we brought a radiologist on site who is doing interpretation like 8 hours per week. We also added Dexa, which is bone densitometry. Our future plans are to expand into ultrasound guided biopsy and cyst aspiration, stereotactic biopsy, 3D tomosynthesis, general X-ray, CT, where we're looking at our feasibility right now of bringing in a mobile cart that would do CT, scan on site. We dump all those studies right into our PACS that's on site. Cart would leave, and then we do all the interpretation, reporting, and then necessary follow-up. So some of the keys to success that we discovered, number one is to gain internal support. We need to engage and educate our staff, training, networking, specifically around imaging, initiate accreditation, referral case management teams, make sure things don't get lost to follow-up. Nothing falls through the cracks, because it shouldn't. Provider relations, promotores, which are health educators. You work on your marketing plans, internal and outside marketing. The billing component. In EHR, in PACS, it does help out. It does facilitate the billing, so you can kind of look at that in a new perspective. You have additional revenue streams that you're able to go after and additional grant opportunities. So as far as the compliance, this has been a huge piece that we're working on. This is going to be a living process for us. Our staff is dedicated to continuous quality improvement activities. So we had to write up new policies and procedures, stay on top of the QI and the QC, peer review, patient surveys, provider feedback. And then these are some of the results, and it equates to better patient care, and ultimately we're saving lives by implementing these services. This is an example of just our first, it was probably closer to 6 weeks of operation mammography. We did 400 patients. About 15% of those had abnormal results. I must say, too, out of that 400, a lot of these patients weren't ladies that did not have mammograms. They had mammograms that were done analog, and the quality was a little bit deficient. And our digital technology was able to detect abnormalities that weren't present using the antiquated technology. We had 3 positive breast cancers. Those manifested with very early detection of microcalcifications, and prognostically they look really, really good. We were also able to assign a patient navigator to help follow up. So we have somebody that does case management, patient navigation, that follows up these cases. We see them all the way through. Just give you a couple individual case studies. So one of them was the microcalcs that we detected with our digital mammography. Key is early detection, better prognosis. We've had a number of great ultrasound cases. Some of our general cases were acute nephrolithiasis that was obstructing a kidney. Was able to be identified rapidly, sent to the urologist to go ahead and retrieve the stone. They used lithotripsy, and the patient did well. Another one came in with generalized abdominal pain. We were able to rapidly detect an abdominal aortic aneurysm that was 5 centimeters, which is within the surgical range. He was becoming symptomatic. We were able to send him over to the medical center, and that was repaired using like a minimally invasive intraluminal graft. A lot of our pediatric cases, pyloric stenosis detected. We've had ectopic pregnancies. We've also had a number of fetal abnormalities that were detected, cardiac cases that were able to be referred to the proper labor and delivery centers where surgical intervention could be on hand, and these kids had a fighting chance and did really well. So that concludes our talk, and now we can go on to the questions and answers portion. Yes.
For your, kind of two-part question, for your mammograms, are you able to give the results the same before the patient leaves?
No, they're not. They're interpreted inside of 24 hours, but they don't leave that same day with the results.
And the same for your ultrasounds. I know in your case study you said that a couple of the companies were able to get.
Oh yeah, absolutely. You know, in all of our cases, I mean, I think the key is to have, you know, veteran staff that have been doing this for many years, and they're able to identify an abnormality in something that is it's a critical finding. And absolutely, yeah, those are detected. Those are we have the formal reports, which we can get back. You know, we have those right out within 15-20 minutes, and then the patient is given a warm handoff to the specialty care.
Well, let me just add to that, because with our primary care docs, what's been super great is when they can call up John or one of his staff and say, "Hey, I got this kid. I need you to scan him right now because I think that this is going on." Okay, great. The scan happens, gets right back with them. The physician then right away can do something. It's not, you know, the usual scenario of sending the patients out. Let's see where they're going to get the scan, how they're going to pay for it, and then they wait for the results. By then they could be dead. Okay?
Or just trying to get in.
Or lost.
Right.
They're lost. Yeah, totally.
Yeah.
So do you think adding that radiologist and having that person full-time on staff has helped?
Yes. Yeah. Yep.
Well, let me just say, the way we were able to afford that is that we only have the radiologist on site for 8 hours right now after the mammography. When we're doing the prenatal ultrasound, you don't need the radiologist. Your OBs will interpret, right? So then when we added the general ultrasound on, yes, we did the teleradiology. So you zap it over to them, and you get it zapped back. And then you show the doctor, and you figure out what to do, right?
Exactly.
Do you do a lot of the services the same day as the appointment, or do you try to schedule the referrals another day?
Both. I think if there's something that's urgent, you know, if a provider expects an ectopic, an aneurysm, a torsion, those are definitely
Does it
done.
impact
Those,
your billing rates if it's same day or the next day at all?
I think it just depends on the entity. There are some, though, that I'm not sure if we can bill for the services on the same day.
That's the issue.
Right.
We're running
But-
across the
Sure.
board, adding it.
And it depends on what, for example, a lot of our mammography is reimbursed by CDP, Cancer Detection Program in California. Okay, I'm sure every state has that. They don't care if you have the visit the same day. Okay, some of the ultrasounds are going to be included in your cap rate, but then your scope, you put in a change of scope, and it all balances out, and it makes many more patients able to be seen and then reimbursed based on your reconciliation later
So are you saying when you put in your scope change, you were able to get a higher reimbursement rate?
for everything.
Yes.
Really?
Oh, yes. I mean, those are some of the perks you don't realize till later. Those are, thank God, you know, it all makes it happen.
Was it from the state or from the federal government that you got the higher reimbursement rate?
It was from the state based on the feds saying yes on your scope.
Okay, yeah.
I guess this is just sort of a feedback question on
Uh-huh.
that. Because one of the things we've had trouble with is, like, for instance, trying to purchase our own vaccine stock for certain vaccines we can't get for our local entities and administering them at our visits. We get paid the same rate for every patient no matter what when they're Medicare and Medicaid. So by spending that money and then not getting paid more, that's a problem. So that was sort of the same question. So you're saying that there's a way.
There's definitely a way to, depending on, you know, what kind of, the first thing you're going to do is sit down and say, okay, what funding streams or reimbursable programs are there for the populations that we will be seeing for ultrasound, for mammo, for whatever. And then figuring out what the rules are for each one of those. Like one of the beauties here is that we're finally able to attract more commercial, which really has nothing to do with any of these requirements that are so onerous that we all live with every day. And how cool is that, that maybe this is a service that could sustain a lot of the underserved and uninsured work that we do. I think we just have to figure out more and more of those models. You know, whether it's your pharmacy going to bring in some money that's going to offset it, or is it the imaging? I mean, that's not why you go after it, obviously, but this is one of the sustainability issues that we look at. Other questions? And we'll be happy to walk through any parts of these with you. This presentation is on La Maestra's website, and it's also going to be posted here from the Public Housing, Health and Housing Conference website. And please contact us because, you know, we know everybody's situation is different. You know, it sounds so overwhelming in a way. You know, I'm looking at it like, God, did that really happen? But, you know, piece by piece, if you look at it and you start, okay, what's happening now? Where are patients going? What are some of the issues? And then, you know, we could help work this through with you. If, you know, any of you have any interest, whether it's on the ultrasound, x-ray, whatever, shoot us an email and get on the phone. You know, this is, figure out if it saves, you know, one life. I mean, just think how much that's worth. And I got the 5-minute signal.
Does anybody currently have any component of imaging at their clinic?
We have it, but we haven't started it.
In,
It's been all approved.
in what modality would that be?
We are going to do regular imaging services for chest x-rays because we have a lot of pneumonia cases.
Okay, general x-ray. Okay.
But the hard piece has been figuring out out the billing, and then the packs if we want to do it on-site or off-site with the radiology. That's where
Right.
we're having trouble right now.
Yeah.
And one of the things with X-ray is that, you know, the reimbursable amount is much less, but your volume's going to be high.
Well, that's what we hope. That's what I'm presenting, because I'm a working person.
Early on, you guys said you interviewed different teleradiology groups.
Mhm.
Then you said that you have the radiologists on site.
Both.
So does that mean, all right, so you use like a storm forward teleradiology for some cases?
Yeah.
And then now, why did you decide to have the radiologists on site? Is it for the acute?
Well, first and foremost, it's better quality care, especially in mammography. You're doing your patients the best service if you have a veteran breast reader, did a fellowship in mammography on site to read for you. They're going to handle all the screenings. They generate diagnostics, studies that need spot views, cone compressions, and then from there they may need a biopsy. Well, having a radiologist on site, you could facilitate all of that. That can be done within the same day. We can also get our on-site radiologist to bunch and read some of our general ultrasound, and then cases that can wait, any of the overflow or any of our acute studies when the radiologist isn't there can be read out immediately by our off-site radiologists.
I mean, eventually our plan is to be, on-site radiologists all the time.
Full time,
But
but
until
we're
then,
not there yet.
use the teleradiology.
Yeah. Other question?
You earlier mentioned you have several satellite sites.
Yes.
Okay. So we have the same problem. We have the main location, we have like ultrasound, X-ray,
Right.
we have satellite site, but the patient seems to get missing between we send them on their way to the main site, they never show up. How do you solve the problem? Because you can't have all those services at all the locations.
Right.
So you send them to your main site to do those services.
We use we have a shuttle. We have internal shuttles that we use to facilitate. We have it available every day. But what we've been doing with some of our mammo screenings is we have certain days out of the week that we'll take from one site. Afternoon from El Cajon,
And
from
those patient
1 to 4.
navigators that are cultural liaisons, they're responsible for those patients. So they follow them. They make sure. They say, okay, you're going to be able to get there. Let me arrange whatever. And so they kind of help that patient get there and get that service done. But we did take our ultrasound for the prenatal out to our other sites. That was, and even if you're only operating it there, half day a week, right? Isn't that what you
Yeah.
guys started? And now it's building up and building up and building up.
In our first year financials, we paid for that piece of equipment the first year. Paid off. So.
Yeah.
Any other questions? Thank you for your time.
Thanks a lot.